Ms. Crowder, whenever you're ready, ma'am. Thank you.
Why did you order 3 separate tests?
I ordered 3 separate tests because I felt that they each show a different parameter or property of the brain, and that each of these methodologies are sensitive for detecting different characteristics of brain injuries or pathologies.
Doctor, what's the first step in evaluating a PET scan?
Well, the first step in evaluating a PET scan is what we call a visual analysis. That's where I eyeball scan and report whether or not I think that there are any abnormalities based upon the patterns that I observe and based upon my years of clinical experience in reviewing the scans to determine if these patterns are normal or abnormal.
And basically, is that what a radiologist does?
That's what the average radiologist physician who interprets PET scans do, is that they eyeball a scan to look at whether or not they have an abnormal pattern.
I'd like you to look at State's Exhibit 3 on page 12. And read what it says under the DTI test.
Let's see. So under the DTI test, it says, please note, however, that quantitative voxel-wise analysis was not performed, as this is not routinely available outside of research setting and may not provide clinically relevant findings in individual patients.
Okay, so they didn't do any quantitative or qualitative analysis, not because you told them not to, but because they don't do it.
And that appears to be their practice, that they don't do a quantitative analysis of DTI scans, despite the fact that it is clinically accepted. There are clinical guidelines on how to do a DTI analysis published by the American Society of Functional Neuroradiology.
I'd like you to look at what's been marked for identification as Defendant's Exhibit 3O.
Yes.
Can you identify that?
This is the corpus callosum tractography of Mr. Anthony Kirkland. And these are 2 different sides. This is the left-sided view of his brain, the corpus callosum tractography, and this is the right-sided view of his brain, the corpus callosum tractography. And one of the things that's immediately apparent that there is a significant asymmetry with the right side of the corpus callosum missing the fiber tracts that are evident on the left side. Now, typically, a corpus callosum tractography is symmetrical, kind of like a mirror or a face, with both halves of the face being approximately symmetrical, not perfectly symmetrical. What we're seeing here is a very gross, atypical difference between the right side of the corpus callosum tractography with the posterior fibers missing compared to the left side. Now, this is the kind of abnormality that we would see in someone who sustained a traumatic brain injury that damages the axon in the right back of his brain.
Sorry, that damages the what?
The axons in the right back of his brain. So this is something that is clearly evident without any kind of quantitative analysis. This is something that can be obtained by a visual analysis of the tractography.
And when these tests were taken at Ohio State, did they do tractography?
I did not see any tractography analyses done by them.
Okay. So these are the results that you found from their test, applying your qualitative and quantitative analysis.
Well, this is a qualitative analysis of the tractography, which they evidently did not do, although this is something that they certainly, I'm sure, could have done had they chosen to do so. It is something that is used in many clinical settings, and they clearly chose not to do a quantitative analysis.
Now, the second test was called an MRI volumetrics.
Yes.
And what does that do?
Well, MRI quantitative volumetrics measures with very high accuracy and precision different structures of the brain, like the amygdala or the ventricles. And this is very helpful because it has been shown that the human eye, even with a very experienced and good radiologist, is incapable of detecting significant differences in the volume of brain structures. And there are peer-reviewed papers that have been published that have shown that the human eye is incapable of this kind of detection, whereas it's quite clinically important now to be able to measure these brain regions, because one can obtain very important clinical information when one obtains a statistical analysis of the different structures of the brain. And Mr. Kirkland had a number of very profound differences statistically in the measurement of his brain volumes.
And how do you measure the brain volume?
There's a company called Cortex. This is an FDA-approved company and they basically will measure all the different regions of the brain. They're sort of like a brain ruler, and it's very accurate at detecting regions of the brain such as the hippocampus or the amygdala. They use a computer program that goes through a process called segmentation, which parses out or pulls out different structures of the brain and then measures them with the aid of a computer. And so this is the kind of thing that used to be done by humans. And so to measure different structures in a brain, it would take a couple of graduate students, probably a week full time, to measure the brain regions. It can now be measured in less than an hour by computer, with probably the same precision. And so something that was impractical previously, like as with so many other things with computers, is now eminently practical and has very invaluable clinical diagnostic information.
And what about the third test? What's the third test?
The third test was the PET scan, which we have been discussing, which is a measure of sugar metabolism in the brain. Sugar is the main fuel for the brain. Sugar is the equivalent of gasoline for a car. So we know that when the neurons are firing, they need fuel. The fuel for the neurons firing is sugar. And so parts of the brain that are more active need more fuel, more sugar, and parts of the brain that are less active need less fuel or less sugar. And so by taking a radioactive sugar molecule and seeing where there is a large amount of sugar being consumed, and seeing where there is a small amount of sugar being consumed, we can generate a map of sugar metabolism which corresponds to neuronal firing or functioning. And so, for example, if we take the corpse and we got a normal MRI of the brain surface of the corpse, if you administer a radioactive sugar molecule to a corpse, you would have zero sugar being metabolized. And so you get a blank screen. And so this is one stark example of how the ability to measure sugar metabolism can help differentiate whether a person is dead or alive. It's something that this CT or MRI scan in many cases cannot do with a cadaver. And you could take someone who is comatose, and this person's brain may be minimally functioning, and so you would see a very low amount of sugar being metabolized, even though that person may in fact have a perfectly normal structural brain CT or MRI scan. And so again, the ability to measure function provides invaluable clinical information that might be missed by just looking at a CT scan, which might appear to be perfectly normal. So the fact that Mr. Kirkland had a perfectly normal CT scan on a number of occasions does not mean that his brain is functioning normally. Just as it doesn't mean that a person is alive or dead or a person is not in a coma or not. And so the only way to tell is to use a sugar metabolism scan in order to determine if his brain is functioning abnormally. And it's quite clear from the PET scan, when you do a statistical analysis using what we call an observer-independent map, that we have replicable significant differences in the PET scan findings, which are consistent with multiple traumatic brain injuries. He has a pattern with this decreased neocortical to cerebellar ratio. And so the neocortex is this part of the brain here. And the cerebellum is this part of the brain here. The cerebellum is involved with things like coordination and balance, and the neocortex is involved with almost everything else, like thinking and feeling and vision and hearing. And he has, his neocortex has less sugar being consumed compared to the cerebellum as compared to normal, which have a lot more sugar being consumed in the cortex compared to the cerebellum. And so this kind of pattern, this decrease in neocortex to cerebellar ratio, is a pattern that I have observed in individuals with multiple traumatic brain injuries. So, for example, I have been involved with looking at many NFL football players who have been part of this lawsuit against the NFL, saying that after multiple concussions that they are suffering from something called CTE. CTE is short for chronic traumatic encephalopathy. When you have multiple brain injuries, this causes the neocortex to burn less sugar than it should compared to the cerebellum. The cerebellum is a more robust part of the brain, which is more resilient and less sensitive to head trauma, whereas the neocortex is a more sophisticated but more delicate part of the brain.
Okay, when we talk about sugar metabolism, are you referring to the FTG?
Yes, FTG, which is fluorodeoxyglucose. Glucose is a kind of sugar.
Okay, it's a sugar or glucose analog.
Yes,
And it's injected into the patient?
Yes.
And you determine from that where the sugar is metabolizing, or the glucose?
Yes.
And what does that tell you?
And so in Mr. Kirkland's case, one of the things that I noted was that he had this decreased neocortical to cerebellar ratio, very similar to the pattern I have observed in individuals who are suspected to have CTE, like NFL football players or other people with multiple head traumas. And CTE is a very significant condition in which an individual who sustained multiple head traumas starts to develop over time at a period distant from the initial insults, in some cases 10, 20 years after the initial insults, significant breakdown in behavioral regulation, including the ability to regulate impulses. And so, I don't know if you've ever seen the movie Concussion with Will Smith, where Will Smith portrays a true life...
Judge, Tim, I object to the... we're going to analyze a movie now.
Go ahead.
Where Will Smith plays a true life physician who noted that CTE findings were present in an NFL football player who had committed suicide. And there was tremendous pushback from the NFL, and they tried
Objection to any discussion about the NFL and their pushback as it pertains to this case.
Go ahead.
And they tried to get him to retract his paper. The movie's about his heroic stand to stand his ground, and other doctors were replicating his findings that CTE was in fact found. And there has been a recent article published in the New York Times that shows out of 110 football players who have donated their brains to science, 109 out of 110 have the pathological hallmarks of CTE. And many of these individuals had significant breakdown in impulse regulation, including significant impairment in their ability to regulate either other-directed aggression or self-directed aggression. So, for example, Junior Seau was
Objection to any comments about Junior Seau.
Was a San Diego football player who had significant behavioral problems. He ended up committing suicide. He shot himself in the chest so that his brain would be preserved for science. It turned out he had significant CTE. Aaron Hernandez.
Objection to any comment, testimony about Aaron Hernandez.
Is a New England quarterback who committed a murder of a friend for no good reason and ended up committing suicide in jail. He had, I think, like a $40 million a year contract. And when they did an autopsy of his brain, he had one of the worst cases of CTE anyone had ever seen. And so you have many cases of people with CTE who, years after the injury, like have these significant breakdown in impulse regulation, especially aggression. And so Mr. Kirkland has this kind of pattern that I have observed in many other people who are suspected of having CTE.
I'd like to get back to the PET scan. You take the information that you get from the PET scan and you feed it into a computer.
Yes.
Is that correct?
Yes.
And what is the result of that?
Well, we have a Z-map which is generated, and the Z-map. Let's see. I don't know. I think we have. Okay, this is Z-map of the DTI. Let's see. I'm going here. I have it here on a PowerPoint.
Here are all the exhibits from the...
Okay. And so on exhibit 3D and 3E, we generate a Z-map which shows all these black spots. These black spots are areas that are statistically abnormal with a P.01 and 30 contiguous voxel cluster threshold. And so we're seeing multiple areas of these black spots in Mr. Kirkland. And so what I've done in addendum 2, so this is in addendum 1 of my report. This is, and anyone who uses my normal controls and runs the same statistical threshold, P01, with 30 contiguous clusters with the age and gender covariate regression is going to get the exact same test. And then what I did in addendum 2 was that I actually measured the metabolism in Mr. Kirkland and measured that in my normative control group. And so, for example, in the right frontal lobe area, normal controls have a metabolic rate of 1.56. Mr. Kirkland had a metabolic rate of 0.94. The standard deviation is 0.11. And so we generate something called a Z-score. And the way a Z-score works is that you take the average, you subtract the patient's value from the average, and then you divide by the standard deviation, gets the Z-scores. And so the best way of thinking about this is, again, with using height as an example. Like if the average American, a 30-year-old male, is 5 feet 10 inches, and the standard deviation is 3 inches, you can calculate how many standard deviations different someone is. And so, for example, if you look at like Will Chamberlain is 7 feet 1 inches. So you could take, and I actually ran this calculation here. Let's see. So Will Chamberlain is 7 feet 1 inches, and so if you count, so that is so 7 feet is 7 times 12 is 84 inches plus 1 is 85. The average male is 5 feet 10 inches, which is 70 inches. So 85 inches minus 70 inches is 15 inches, and the standard deviation is 3. So you divide 15 by 3, and Will Chamberlain is 5 standard deviations different from the norm. That means about 1 out of 3 million people are as high as Will Chamberlain, okay? Well, this is the kind of abnormality that we're seeing here in Mr. Kirkland. He is more than 5 standard deviations lower in the brain, and so he's kind of like the opposite of Will Chamberlain, except in the opposite direction in his brain. So the odds of this kind of abnormality occurring in the brain are like 1 in 3 million, or probably 1 in 6 million. So this is in this case it's 4.8 times 10 to the minus 8, which is 10 to the minus 6 would be a million. 10 to the minus 8 would be 100 million. So this is 4.8 out of 100 million people would have an abnormally low value, this low. And so I did that with multiple other areas. Now,
okay, are you looking at what the computer produces? Are these slices that
Well, these are slices of the brain, and then I'm looking at where the Z-map indicates that there are abnormalities.
Is this a slice of Mr. Kirkland's brain?
This is a slice of Mr. Kirkland's brain. Yes, I'm sorry. Okay, sorry. I know it's hard to. Okay, and we can do the same thing in other areas of the brain. So, for example, in the right temporal lobe area here, we can see that the normal controls have a value of 1.48 in terms of their metabolism for this area. He has a value of 1.05. The standard deviation for this area is 0.07. So this is over 6 standard deviations lower in Mr. Kirkland than normal. This is like 1 out of 5 million people would have an abnormality this low. This is very abnormal in the normal population, but this is very common in a person who's had a traumatic brain injury. I see these kind of Z-scores and p-values all the time in people who sustain brain injuries. And so this is very consistent with his history of having been struck in the head multiple times as a child, especially when a child's brain is very delicate, or his having been in his industrial accident at 17, or his bicycle accident. And so I can't say exactly when this occurred, but I can say that he certainly had abnormalities consistent with those type of events. And so, he has multiple other abnormalities in the brain. So, for example, if we look here, this is the area of the brain where he's abnormally hot. And this is the area that's in the parahippocampal gyrus. And this is something that we see bilaterally. And so the normal controls have a value of 0.76. He has a value of 1.01. The standard deviation is 0.07. So 1.01 minus 0.76 is about 0.25 divided by 7 is roughly about 3.5 standard deviations above the norm. Or this is roughly, maybe 3 out of 10,000 people would have this value this high. Now this kind of value is seen in individuals who have something called epilepsy spectrum disorder. Now it's not uncommon after you've had traumatic brain injuries for people to develop something called epilepsy spectrum disorder. Now epilepsy spectrum disorder doesn't mean that you necessarily have tonic-clonic motor activities, but it does mean that there are abnormal electrical firing in the brain areas that are damaged. And so this is very consistent with someone who has an epilepsy spectrum disorder, and it's very consistent with abnormal firing. And this is the area of the brain that's very important for emotional processing. And one of the things that happens with people with epilepsy spectrum disorder is that when they are stressed, they can act out aggressively in a way that is hard for them to control. And judging from the accounts I've read of Mr. Kirkland, he had episodes when he acted out aggressively in ways that he seems to feel he was having trouble controlling himself. And so this would certainly be consistent with an epilepsy spectrum disorder where the brain is firing and discharging and triggering emotional circuits in the brain that an individual is not capable of controlling.
Are these colors produced by the computer?
Well, these colors are color-coded to sugar metabolism. So areas of the brain that are higher in sugar metabolism are going to be color-coded hotter colors like red, and areas of the brain that are lower in sugar metabolism are going to be colored cooler colors like blue. And so there's what we call a rainbow spectrum: red, yellow, orange, green, violet, blue. And so depending upon how much sugar is being consumed in different parts of the brain, it will determine what color that part of the brain is colored.
Would anybody using the same test be able to replicate this?
Yes, if anyone were to pull up Mr. Kirkland's scan and they were to do the same kind of SPM analysis I did, using the same parameters and the same normative controls, with the same, they will get the exact same results. I've done this, and you will get the exact same results when you rerun this test, and if you do this test correctly.
I'd like to show you what's been marked as States Exhibit 1. In the top of the page, it says SYNCOPE. Can you tell us what that is?
Let's see, the top of the page, let's see, oh, which part here? Oh, syncope. Syncope. Syncope means fainting, blacking out.
Okay, and does this report note remote left medial orbital wall fracture?
Yes, this indicates that there was an old left medial orbital wall fracture. So this would have been 5 years after the 2004 bicycle accident. And so this is very consistent with a fracture of the zygoma from the 2004 accident.
Now, no one can say if you have CTE when it's going to affect you or what's going to happen.
That's correct. The exact timeline is going to vary from individual to individual, but it's interesting to note that here they indicate that he has possible seizure disorders, and this is very consistent with his PET scan finding of this abnormal increase in the parahippocampus.
It says on the syncope head injury next.
Yes, head injury now is possible seizures. And so what we're seeing here is objective evidence of a seizure spectrum disorder. This abnormal activation in the parahippocampus is what we see in people with seizure spectrum disorders.
I'd like you to look at what's been marked for identification as defendant's exhibits 3N1 and 3N2. What test did this come from?
So these are the DTI scans that we analyze using what we call a statistical parametric map of quantitative analysis, the kind that Ohio State says they do not do, but which can be done clinically. There are clinical guidelines for doing these kind of tests published by the American Society of Functional Neuroradiology, and it is an accepted clinical tool for DTI assessment, although the Ohio physicians did not choose, the Ohio physicians were either not aware of this or choose not to do this for whatever reason. But what we see here are these red regions here. These red regions are areas that are statistically abnormal. In this case, these are areas of the red region that are statistically abnormal with a P equal to 0.01 with a 30 voxel extent threshold. That means you have to have at least 30 or more voxels, all with a P less than 0.01 to be flagged as abnormal and colored red.
What's a P?
Well, P value is a probability value. It's a 1 chance in 100 of a particular voxel being that low by chance alone. But when you have 30 of them, all right next to each other, having that 1 out of 100 chance, then this is not just a random noise. This likely represents some significant pathology. In this case, a significant decrease in the fractional anisotropy, which is a measure of DTI in Mr. Kirkland. And what we're seeing here is that we're seeing a significant decrease in the right posterior internal capsule. And so the average FA value in this area is 0.48. His value is 0.33. So that's about, and the standard deviation is about 0.04. And so this is about 4 standard deviations below the norm, or about 6 out of 10,000 people would have it by chance alone. The typical medical threshold for being significant is 5 out of 100. And so this is very consistent with some kind of right-sided head trauma at some point in time.
Doctor, so other than the visual analysis, is that where you start from there and where the radiologist has stopped?
Yes. So I do the visual analysis also, but then I add a statistical and quantifiable numerical approach, which I believe is absolutely essential when you're trying to get the most accurate assessment of a scan, which is something that was not done by Ohio.
In fact, they commented in the report that they generally don't do those tests.
Yes. And so...
These are tests that are recognized in clinical use?
Yes, and ZMAP approach for DTI there are clinical guidelines for its use published by the American Functional Society of Neuroradiology, and it is being used by clinicians who are knowledgeable and up to date about how to use these kind of methods in the assessment of DTI.
And when the information is fed into a computer, what software do you use?
Well, I use a software called SPM. This is a widely available software. Anyone can download software and run it, and it's used in thousands of medical imaging articles. It's probably the most widely used medical imaging analysis software in the literature.
May I have a moment, please? And you've been questioned here by Mr. Gibson. Is there any opinion that you changed from your first deposition back in November?
No, I haven't changed any of my opinions.
And are your opinions to a reasonable degree of medical certainty?
Yes.
And as a result of your testing, you're picking up where the radiologist stopped. Do you feel that Mr. Kirkland has significant CTE or?
He has a pattern very consistent with other individuals who've had sustained multiple traumatic brain injuries and who are at high risk for CTE. Now, CTE is currently definitively made only upon autopsy, but people who have suspected history of likely CTE have the kind of pattern that I have observed in Mr. Kirkland of this decreased neocortical cerebellar ratio, and it's very consistent with his history of multiple beatings when he was a child, his the industrial accident at 17, the bicycle accident was just a facial fracture, and then significant behavior change that was noted by Roberta after the bicycle accident, and so the evidence is quite pronounced. If you look at the quantitative volumetric data, too, I mean, he shows a enlarged left lateral ventricle. So that means the left lateral ventricle, the ventricle is a part of the brain that will be in this area here. It's a kind of a fluid-filled cavity, and that fluid-filled cavity gets larger if that side of the brain is damaged because the brain has shrunk on that side. And so his left lateral ventricle is statistically significantly enlarged. And so this is consistent with some type of old left brain injury that caused enlargement of the left lateral ventricle. And then he also shows significant abnormalities in the right thalamus. So his right thalamus is much smaller than normal, and again, this is consistent with someone who sustained a significant right-sided brain injury sometime. So, because you're not going to get a shrunken right thalamus and a large left lateral ventricle in the same accident. These have to be at least two distinctly different injuries to get a left lateral ventricular enlargement and then a right thalamic atrophy. The other thing that's remarkable about his quantitative volumetric is that he has an abnormally enlarged amygdala. Now, an abnormally enlarged amygdala, it has been reported in individuals with severe emotional neglect. Like in Romania,
Objection to the Romanian study or whatever it is.
In Romania, there were abortions were prohibited, so many Romanian families had many more kids than they could handle. These kids were placed in Romanian orphanages where they had minimal care. I mean, they were basically fed, but they had no emotional nurturance. And these kids grew up with severe behavioral problems And an American parents were trying to adopt these Romanian kids, found out that they were in for a handful. And one of the things that was noted is that these kids have enlarged amygdala. And Mr. Kirkland has an enlarged amygdala, very consistent with the kind of amygdala enlargement seen in severely neglected Romanian orphans. And it's very consistent with the kind of history that he reports, where his mother was described as being very distant, his father was very physically abusive, and so he has a structural abnormality in the amygdala. The amygdala is a part of the brain that processes fear and emotion, and his amygdala is about 30% larger than normal, and it's a significant enlargement. Now what's interesting is that the Romanian orphanage studies found that the amygdala enlargement was bilateral, that is both sides of the brain were enlarged. Now he only shows a one-sided enlargement of the amygdala. Now this is, in my opinion, consistent with his probably having initially a bilaterally enlarged amygdala of right and left side, but due to some trauma on the brain, we know that trauma causes shrinkage. And so the trauma probably caused, in my opinion, the abnormally enlarged left amygdala to activate down to normal size, which is why the left amygdala is no longer significantly enlarged. In my medical opinion, there's no other explanation for why his right side of the amygdala is so enlarged, but his left side is normal, other than the fact that he probably had a bilaterally enlarged amygdala due to severe emotional neglect, and the left side amygdala shrunk down to normal after it was some type of head trauma. And
based upon your findings, would you expect Mr. Kirkland to have difficulty controlling his behavior?
Yes, I would say that we know that from medical studies that individuals who grow up with severe neglect and abuse, but they have a normal brain, are more likely to survive emotionally unscathed and are able to grow up in later life. But we know that if you grow up with severe abuse and neglect and your brain is injured or damaged, you're much less likely to be able to have a normal life. You're much more likely to act out aggressively because the damaged brain is not able to learn how to cope with the severe emotional neglect and abuse. And so what I've seen in Mr. Kirkland is that he has clear evidence of multiple different types of damages, from the enlarged left ventricle to the shrunken right thalamic volume to the significant asymmetry in the amygdala volumes to the abnormalities on the DTI with the right corpus callosum tractography to the abnormalities on the DTI-Z map with the decrease in the FA to the PET scan abnormalities with this decreased neocortical cerebellar ratio. I mean, he has findings in spades of multiple causes of brain injury, and he also has findings in spades of having grown up in a severely neglectful, severely abusive environment. And so it is not surprising to me that he is going to have significant difficulty regulating impulses. And it seemed like, in particular, the 2004 bicycle accident with the right-sided facial fracture on the zygoma, which shows up as remote facial fracture in 2009 X-ray, in which he has possible seizures, and is the one where Roberta noted that he had a significant change from being a church-going, job-holding, nice guy with her and taking care of her kids, helping her to pay her bills, to someone who becomes homeless, who is no longer welcome at the church, who ends up threatening his son, I mean, it's clear that this, in my medical opinion, this 2004 accident took someone, this 2004 accident on top of all the other situations that he had, with all the physical beatings, with the industrial accident when he was 17, pushed him over the edge, in my opinion, in terms of his ability to regulate his impulses.
Thank you. I have nothing further.
Doctor, I just have one area I want to talk about, and then maybe it's obvious. When you received the scans from the Ohio State University, they were done in a grayscale, is that correct? They did not have the bold, vibrant colors that we see in these later photos you identified with Mr. Kutcher, is that correct?
The data is provided to me in a numerical format. The data has no color, gray or rainbow. It's numerical. And so the manner in which it's displayed depends upon how you choose to display the numerical data. And so the data is inherently color neutral mathematically.
But you added the color to those scans that you showed us for use in your comparison process. Is that correct?
I use both a grayscale and a rainbow scale, which is a customary approach by many physicians who read PET scans, who utilize both a grayscale and a color scale. So, but it is something that I took the mathematical data that describes metabolism and used a rainbow scale and a grayscale color lookup table to display that mathematical information. But this is commonly done by many physicians in this field.
I'm just asking if you added the color that was you that did that on the scans that you showed us.
I use what we call I use what we call a color lookup table, which converts the mathematical values of the glucose metabolism into the corresponding colors.
That's what I wanted to know. Thank you. I don't have any further questions.
Nothing further.
Here marks the end of today's videotape deposition of Dr. Joseph Wu. Going off the record, the time is 3 p.m.
All set? Okay, thank you. Thank you, ladies and gentlemen. I know we had a discussion at this point. I believe the state's going to call a witness. Is that correct?
Yes, their next witness is not going to be available today. We indicated it's okay. I think both sides agreed we would call some of our rebuttal witnesses ahead of that person.
That's absolutely correct. There's no objection to that procedure. That's for the convenience of both sides. Thank you.
All right, thank you both very much. I'm sure you all heard just what went on there in order to try to keep it moving for you, and quite frankly, arranging schedules and all those other things. Counsel, and I appreciate their cooperation and professionalism, have indicated they're going to kind of call a witness now out of order, okay? Whoever calls the witnesses, you still use the test that you're going to be told about to judge credibility, so it's all part of the same thing in a way. With that, though, I need to check. Is everybody okay? Okay. And I don't know offhand. Oh, good. You're more than welcome to stretch. To absolutely do that. How long? No, that's fine. Okay. Okay. I mean, that's fine. No, that's all right. We'll do the hour. That's fine. What we're going to do, quite frankly, ladies and gentlemen, to accommodate me, I did not ask for a whole lot, but there's a very good friend of my family whose funeral is at 1 o'clock, and I asked them if there's any way we could work around that, and everybody was very cooperative with me. So if you guys can hang in for an hour, we'll call it a day at about quarter till 1, okay, and then come back tomorrow. Everybody okay with that?
How about this? How about we play the deposition of Dr. Wright? It's 37 minutes. That way, Chris can get the transcripts passed out. You can explain again that there are objections that are, I don't think there are any objections on that at all, so just play it right through.
Just real quick then, and tomorrow then, will we have something for the jury?
Absolutely. We have a live witness, stage witness, rebuttal witness, and then the other one that we're not going to call today.
Okay. All right. And I think, and maybe this will help. Don't hold me to this, okay? But I think we can get this case to you if everything breaks the way it's supposed to, as far as the everything that you need to hear, and then to begin your deliberations would be on Monday. Okay. So first of all, you don't have to worry about the weekend. You're not going to have, we talked about sequestration. We'll talk to you again about that. That's not going to happen over the weekend. The first time that would occur is on Monday. So hopefully that helps a little bit. We'll try then, if you don't mind, we'll do the 37-minute one today. We'll have some things for you tomorrow, and then we'll wrap up the evidence on Friday. Okay, everybody okay with, I'm a little out of order here, but you need to know that, okay? Is that okay with everybody then? Just keep going? Okay, I do appreciate that, and I think Gino Trotta would appreciate that, the guy money.
The next one is check, right? That's the land grab.
While he's doing that, ladies and gentlemen, again, you're about to hear a videotape deposition. By agreement of the parties, each of you will be provided a written transcript of the testimony to assist you. Should you find any discrepancy between what you thought you heard versus what you see in writing, the audio controls, you will decide based on the audio. Did you get... Well, Andy went to lunch.
Let's pass all about the food.
Yeah, I was going to say, get those. You go and help him real quick. Chris, you got a helper here. Just give him the Dr. Wu's. He was just recruited. He's just watching, but he needs to do something, so he's going to help a little bit.